Good evening, ladies and gentlemen. It's a pleasure to be with you again. We'll be continuing the journey of aesthetics from composite to ceramic. We are now at the level of the ceramic part. The advantages of the composite, just to summarize what was said in the earlier webinar. Advantages of composite, we can get an immediate result. It's a non-invasive technique. It's easy to repair and change. The problem is that we're going to have an aging, discoloration, and soft tissue reaction because soft tissue does not react well to resin composites. Porosities of the composite while we're doing it or intrinsic to its properties can create aesthetic problems. And the layering, if the layering is not properly done, you can have some discoloration on the layers that were used. When we talk about ceramics, what were the advantages of the composite will be the disadvantages, and what were the advantages will be the disadvantages. Meaning that the disadvantages is a deferred result. So you cannot just take it in one session. It is invasive. No matter what we say, no matter what we do, we'll always have to work somehow on the enamel and on the tooth. It's not easy to repair or change. The advantages are on the aging. The aging, it ages much easier, much better than the composite. The color does not change. It's a stable color. Soft tissue reaction, the soft tissue accepts much better the ceramic than the resin, cement. Resin, composites, the porosities we don't have, layering we don't have. So why do we need it? Why do we need to do some ceramics? We need them to use to clear out stained teeth, dark teeth, hypocalcifications, multiple diastemas, peg laterals, chipped teeth, lingual positioning of the teeth. But please don't use veneers and ceramics to correct malpositioned teeth. Send them to orthodontics. It's much easier, much safer. Contraindication, insufficient tooth substrate. If we're using the veneers, enamel is your partner. If you don't have enough enamel, you're going to have problems. Labioversion of the teeth will have to cut a lot of the tooth, and thus compromising the tooth. Extensive interdental spacing also needs to have orthodontic treatment or different approach. Poor oral hygiene or decays, caries is a situation where ceramic is not the best solution. You have to train your patient, educate your patient before doing any kind of this treatment. Parafunctional habits, clenching and bruxism is a problem to ceramic because ceramic is brittle and it might break. If you're thinking about the full zirconia crowns, we're going to discuss it maybe along the presentation. Moderate to severe malposition or crowding also is a contraindication. Send this treatment to the orthodontist instead of doing instant orthodontics with veneers and crowns. I'm going to catch up on a case that was presented last time, how we can treat a case like this, and to bring her from the picture above to the picture on the lower of the screen, is with the help of the orthodontist to create the projection. Can we do veneers for these cases? Definitely not. No matter what you do, a veneer or a full crown, the process is irreversible. The veneers are mostly costly, and composite resin bonding also is not the solution in these cases. Veneers are usually not repairable and should they chip or crack. Because enamel has been removed, your tooth may become more sensitive to hot and cold food and beverages, compromising the health of the pulp and leading eventually, in some cases, to necrotic pulp. Veneers may not exactly match the color of your teeth or the other teeth, adjacent teeth. Also, the veneers color cannot be altered once it's placed. We cannot just change it. If you plan on whitening your teeth, you need to do it before doing any ceramic or any crowns or any veneers. Once you have the veneers placed, you're not allowed to bite your nails, chew your pencils, a buzzer, or other hard objects, or put excessive pressure on your teeth. Teeth with veneers can still decay because you still have the margins outside and the margins can decay. Veneers are not good choice to unhealthy teeth. Weakened teeth, or if inadequate amount of enamel exists on the tooth surface. We need to have enamel. Your partner is the enamel. Clenching and grinding can cause the veneers to crack, to chip, and to debond. So we're going to talk about the ceramic veneers. We have three types of ceramic veneers. It could be the facial window, where you just layer the veneer on the surface of the enamel, removing a slight quantity of enamel. It could be the incisal wrap. The incisal wrap will go beyond the incisal edge, and we have a reverse curve on the palatal side of the tooth. And this we are not using much anymore as much as before. Incisal shoulder, this is what we are using most commonly, where we stop at the edge of the incisal, at the incisal edge, and we cover the full incisal edge. So, but before doing any kind of these preparations, the question would be to prep or not to prep. Are we going to prep the tooth to place a veneer, or are we not going to prep the tooth? Is it going to be a prepless tooth? It will depend on the insertion path. If you have a path of insertion that is obstructed by any convexity of the tooth, it has to be reduced, then you have to prep. Limited correction of the position of the tooth, definitely if you need to do so, you need to have a limited correction of the position of the tooth, not much, because you need to still be in the enamel. You need to manage the size. If you're going to prep or not, it will depend if you're going to keep the size of the tooth or you're gonna extend the size of the tooth. Color correction, finish line. You'll definitely need to have a finish line for the lab to have a good job and to know where it's in. Keeping or reducing the size of the tooth. Do we need to add volume or augment the tooth? Two techniques, two different approaches. If we're keeping the tooth or reducing the size of the tooth, definitely we need to prepare. We need to remove a certain amount of enamel to be able to replace it with the same amount of ceramic or less. But if we're adding a volume, the preparation should not be as extensive, but will have a better preservation of the enamel. Look at this case. This is a patient who had, after orthodontic treatment, a recurrent repositioning of the lateral to a more palatal and more apical position. Twice it was corrected orthodontically. When the retainer palatally will debond, the laterals will jump back into palatal and more apical position. For this patient, we need to augment the volume of the tooth. So it will be definitely a prepless tooth. As you can see, this is the bite that she has. We need to secure a better overlap, not to have a lateral sliding into a class 3. For that, we look closely at the tooth. It's a tooth that has full enamel. It has a nice translucency. We can just prepare a veneer, prepless veneer for this case, and put the tooth into a proper position with a slight overlap to secure the occlusion. On the other side, it would be done the same. As you can see, it's a very limited marginal preparation where to give the patient, the lab technician, a line to stop on, and accordingly a veneer is prepared, and this veneer is cemented in the mouth, is bonded in the mouth, and the occlusion has been secured, as you can see on the upper right side of the screen. Matching the color of the veneers is difficult in these situations because it will be one tooth in between adjacent teeth. Nevertheless, your close cooperation with the lab should give you a good result. And you can see the aging from 2013 to 2017 on this slide. You can see the aging, the nice aging of the veneers on this case. And this is the happy smile of the patient. In another situation where lip filling, as I consider it if not properly done, is a smile killer, brought this patient to us. It's true that these lips are very full and nice and static, but in dynamic, you can see that the upper teeth are not showing. This patient is in her mid-20s. Basically, when you have a class 2 division 2, as in this case, the lip filler is not indicated or should be indicated with caution, because the lower lip will have the shape that you're seeing on the screen. It will unfold buccally, and you can see on the right side of the screen the line of the inner part of the lip is showing, as you can see here. This belongs to the wet area and it's not supposed to show. Also, we're showing the lower teeth, and the main actors in the smile are the upper teeth are not showing. As you can see, this is her occlusion. She has a nice occlusion, a good occlusion, but unfortunately she has a reverse upper curve of the incisors. When approached for orthodontic treatment, she refused, and systematically refused. But analyzing the situation, even if we do orthodontic treatment, we'll have to end up doing some veneers layering because of the size of the teeth. And the laterals are too small, and the centrals are relatively too small also. We needed to add some width to the teeth. For that, it was decided to do almost a prep-press veneers for this case, to align this. So are we changing the size of the teeth? Yes, we are changing. We are augmenting the size of the teeth. For that, we don't need to prep. We don't need to prep much. We only need to do some insertion path preparation. Before doing anything, a mock build-up with composite was used. As you can see, the curve is much closer to a proper curve, and it's showing much more in her smile. When the patient accepted the projected smile that we were going to give her, we went into the preparation. As you see, almost prepless veneers, just a minor line, finish line on the proximal area, on the marginal area. At this situation, on the left central of the patient, the margin was supragingival in the enamel, not to go into the dentine. Only 4 teeth were prepared, polished, prepared, and the veneers were given to this patient, and it was 6 teeth, the 6 teeth from canine to canine. The size of the teeth were augmented. The patient has been advised to use also to cover the first premolars, but she had refused. That's why you can see the extended size of the canines distally more than it should have done. But for the patient, this is the frontal view that we could do. We could not have longer incisors, because if the longer incisor will impinge on the lower lip, and the phonetics of the V and the F will be compromised. For that was the maximum of length that we could obtain with this build-up technique. As you can see, the transformation of the smile of the patient from your left side to the right side. When we talk about veneers cannot easily cover discolored teeth. When you have teeth with root canal, and this is the teeth of a colleague dentist, she refused to have crowns on her teeth, and she had endodontic treatment. Are we keeping the size of the teeth? Yes, we are. Are we going to prepare? We will definitely prepare if we're going to keep the tooth in their position. What was advisable in this situation? Knowing that this tooth, if we're going to keep the size, we're going to prepare the tooth. If we're going to prepare the tooth, we're going to remove the enamel. And removing an enamel on the tooth that has been endodontically treated And bleach, as you can see on the palatal side of the lateral incisor and the canine cavity, is immense for the breaching, would compromise the stability of the tooth or the resistance of the teeth. For that, what we propose for this patient, knowing that every time you cut on a dark tooth, the deeper you go, the darker the tooth is. The dentine is the dark part, the enamel is the clearer part. So it's more advisable not to touch the enamel and don't get as close as possible to the dentine. Keep the enamel safe in these situations. For that, upon her insistence, we advised her to do some orthodontic treatment by bringing the teeth, the central and the lateral and the canine, more palatally. It will interfere with the palatal occlusion, with the occlusion palatally. Palatally, it's a composite. We can reduce the composite. Instead of cutting the enamel on the buccal, we can reduce the composite from the palatal and bring the teeth more palatal. As you can see, clearing the contact points will give us the possibility to bring the teeth palatally with a simple orthodontic appliance that was removable appliance, and a margin line was created just for a finish line for the lab technician. You see, the teeth are more palatal, and we have created the space for the veneers without touching the enamel, just a finish line for the ceramist to finish his preparation. Here is the difficulty or in the lab. As you can see, this is the finish line. We have kept the size of the tooth. We have created enough space to keep the size of the tooth. But the color matching of the veneers is the most difficult situation in this case. And in this case, we had to do 5 setups to get to as close as possible veneers that we could get. It's not a perfect match, but we'll never be able to get to a perfect match. As you can see, we can also apply it to different situations where the central incisor, the number 11, was brought back slightly, composite was removed, and then ceramic veneer was placed and restored without practically touching the enamel. If you lose the enamel, you lose all the retention that is possible on the ceramic veneer. The situation of this patient who was complaining about her smile with a long face, with an open bite, this is not a situation where we have a lot of stress on the ceramic. But as you can see, hygiene was to be re-evaluated and reapproached. Once the patient was properly cooperative with the hygiene, and she had refused to do any surgical and orthodontic treatment like a Lefort 1 or double jaw surgery, we tried a setup with the composites, and this patient was very happy with what she got. This was just an idea to give her what we can do with the composite. But as you can see, by adding on the surface of the teeth, we have augmented the size of the teeth. But this is too much because it was done on direct in the mouth of the patient. But just to give her an idea that lip at rest, we can gain that much. Lip at smile, as you can see, we can change her smile and her self-confidence. Once we agreed upon the treatment, the preparation for this patient was to remove all interferences, decays, composites, because we'd like to set our margins on pure enamel and not on composite or decayed restorations. For that, it was prepared, and this was, as you can see, the preparations. We have 6 anterior veneers and some veneers on the premolars, partial veneers on the premolars, and the canine was full coverage, as you can see. This is the final result. In this situation, there is no occlusion, there is no force to be exerted on the veneers. We could have some dentine bonding in these situations. This is the change that we received, not much on the facial change, but on self-confidence and smile, this is the patient that is more self-confident. But what happens on the long term? If we have a veneer that is placed on the long term, what happens? Veneers, it's true that are very successful for a long time, but in some situations we have complications. We have to understand that the tooth, when it is veneered, it is subjected to a bonding. The bonding is in red, and the veneer is bonded to the tooth. And your partner is the enamel. If you don't have more than 60% of enamel, you cannot do a veneer. And the most interesting part of enamel should be at the cervical area. Ceramic can bond to the tooth and to the composite. But when it is subjected to the occlusion, the tooth is not stable, it's not rigid. It's not that rigid as you think. The tooth will flex, and the flexing point is always at the cervical area. And that's why some of these erosions that we experience with clenching people are due to the heavy bite and the flexing of the teeth. When it flexes, the contact between the ceramic and the tooth will be subjected, the bonding between the ceramic and the tooth will be subjected to a lot of shear stress, and this shear stress is drastic for the bonding of the ceramic. Pascal Mann have published that if you remove 1/3 of the thickness of the enamel, just 1/3 of the thickness of the enamel, the flexion of the tooth is multiplied by 10. What can happen if you remove the whole enamel and do a crown? The flexion is more dramatic. For that, as you can see here on this picture, you see the veneers are aging on their cervical area because this is the point of stress. You can see that we lost on the number 23 part of the ceramic, on number 11 crack, on number 13 part of the ceramic on the cervical area, and these teeth are veneered, as you can see. And when I talked about a reverse preparation, reversed curve on the preparation, you're not supposed to cover the palatal side. You're supposed to be flat, because if you have a coverage on the palatal surface, also by the flexure of the veneer, you will have fractures on the palatal sides. For that, the preparation should be only an incisal preparation and not a reverse curve on the palatal. As you can see, different situations, different fractures, different problems of the fractures, and definitely all of them on the cervical area of the veneers. The other issue with the veneers is the weakest part of the whole system is the composite that is bonding the veneer to the tooth. And it is, as we said, a sponge, discoloration, collection of the bacteria, and all this excess of cement will show with time, and the gingiva will avoid this kind of material by having some recessions, and it will go away from the margin that is in composite. You see the aging of the veneers. You can see here closely the fracture on the canine that was subjected to too much pressure on the cervical area, as I said, because we have less enamel on the cervical area, and this is the point where you have all the stress. And as you can see, the line of cement, the composite cement that is on the lateral incise. Debonding, it will happen. You cannot rely on dentine as it is on this situation. Dentine is not a reliable bond for veneers. You can see also the margins will decay. If the hygiene of the patient is not enough, the margins will decay. There is no enamel on this number 21. That was the reason where the veneer jumped. And plus that composite restoration is bonded to the veneer is bonded to the composite restoration. This is something you should not do. Veneers will crack, or layering of the veneers will crack. This is a situation where you can see after 12 years of function, the lower 43 was fractured, and you can see many fractures, internal fractures of the veneers in this situation. Patient insisted of having them again. These were not veneers practically, there were 3/4 crowns. You can see they were redone, re-cemented in this situation. Patient is abraxar, is fracturing the ceramic on the lower 44. It will happen sometimes that it will debond because there is not enough enamel to hold the veneer or the crown again. Whether it is a feldspatic veneer or whether it is a desilicate crown, like Emax, I'm going to name it, the bonding is composite bonding, and the composite is weak on the dentine, is not as strong as we would like it to be as in enamel. The contraindications of these veneers is situations like this, where really it's not only a facade. Look how criminal is this situation, where all these veneers are done on teeth that were supposed to be fully crowned, endodontically treated, composite badly managed. This is not the way we'd like to approach these kind of veneers or aesthetic veneers. Again, keeping the colors in the acceptable aesthetically for each patient is something. This patient presented and asked me to do the premolar number 15, the same color of these teeth. I told her, Madam, it's not, I don't have the material that has matched, that can match this type of veneers that you have. Anyway, you have a lot of overhang on all the teeth. Actually, I was treated as a dentist that does not know what to do. When approaching situations with this type of aesthetics, minor malposition, we could do some composites, some ceramics, and correct the aesthetics. It has to be approached properly if it is a full ceramic or a veneer that should be used. I'm going to give you the example of this patient who has been treated for a cleft palate with a complex orthodontic and craniofacial surgery, implants, and bone grafting, and all that. This patient has multiple missing teeth. She has, the laterals are missing, canines, number 23 is missing, first premolar on both premolars on first premolar on the left side, number 24, and on the right also there is a missing premolar. No matter what we try to do and to bring this premolar into occlusion, the premolar would rebound apically. When discussed with the orthodontist, also the position of the central incisor could not be kept in their proper position. This is at the temporary stage after ortho treatment. So what to do? We try to approach this patient by building up the smile and building up the site that is to be built according to an ideal smile. You will see the missing parts of the teeth in her. We copied this and we gave her this without bonding to the enamel, because we don't want to compromise the enamel that we have with bonding composite to it. We'd like to end up with the ceramic veneers. An eggshell is supposed to be given to her to protect these teeth not to fall when she is functioning in eating and speaking. This is the project that was prepared. As you can see, this project comprises a veneer on the canine, full crown on the implant on the missing lateral, 2 veneers on the central incisors, a crown on the canine with an pontic on the lateral, and a veneer on the premolar that is rebounding apically. This is the smile of the patient. She accepted the smile, As you can see on the right side, she has a molar. She has canine and molar. She has missing 2 premolars. This is how she functioned for the time of the preparation and the finalization. You can see that there is a minor preparation on the central incisors, just a finish line that was drawn on the premolar and the canine. This is a close-up view of the central incisors. You can see the very thin finish line. It is not a wrap technique, it's only a incisal edge technique where we stop as a butt joint on the incisor edge, and proximally we have the finish line, a similar a very thin finish line, and you can see on the distal side we created a thin finish line for the lab to know where to stop. Same thing on the canine on number 13, and this is the finish line, a butt joint on the incisor, and this is the molar that was untouched. You can see on the premolar side, which is on the 25, that was a full occlusion veneer because this tooth was rebounding and going apically. We needed to give her occlusion. Impression, whether you do it analog or digital, it's the same. It's appropriate to your convenience and how you can work with your lab. Positioning the crowns. And the most difficult was to match these colors, because on ceramic, on the implants, you have an abutment underneath, you have a different material. It will be a zirconia material based crowns, while on the veneers it will be a feldspathic or a disilicate ceramic. It's a different light translucency. This is the final work. As you can see on the number 13, it's a veneer, the crown on the number 12, 11, 21 veneers, pontic with a crown on the 23, and the full veneer on the premolar to transform it also into occlusion. This is the amount of material that was used. You can see between the lower picture and the upper picture the difference of the ceramic that was used. Bonding it is step by step by etching the ceramic with fluorhydric acid, silaning it, drying and separating the teeth, etching the teeth, isolating each tooth together on the side with Teflons, not to have any cement interfering. We do not remove all the cements, definitely not the gingiva level, because we will have a bleeding if you just do it. Just remove what is necessary to be able to cement the other side before finalizing both sides. As you can see, now we are removing the excess on the gingiva, because if we have a bleeding and it will contaminate the side, then we will have a complex situation. For that, now we will go to and remove the cement on the number 21, and you can see how the whole thing was approached. As you can see, the whole cements were done. The margins are supragingival. This is the day of the cementation, and you can see her sometime later when the tissue integration was done. You cannot believe how relaxed these patients become, how confident in their self-confidence these patients become after so long treatments. Since they were born until the age of 20-22, they won't be able to smile. They will always have a compromised smile. As you can see, much to be done also on her facial appearance, on the nose, but these are not our job. What to keep in mind? What to keep in mind at the end of this presentation, I would say, ceramic veneers is an irreversible technique. Once you put a ceramic on the mouth of the patient, it means that it will stay or it has to be redone. Keep the enamel more than 60%. As much as possible you have to keep. And the most important part of the enamel that was supposed to be kept is on the cervical area, as much as possible. Bonding to dentine is good, is not very predictable on the long term. Debonding is frequent if the enamel is not sufficient. Marginal aging will happen. It might age because of the composite, it might age because of the stress on the occlusion, and it will crack eventually. The word of caution from Michael Zook. Michael Zook is a guy that was known as the king of veneers. He wrote books about how to change the smile in one day. The problem of the overuse of the veneers by certain cosmetic dentists is reflected in the confessions of a former cosmetic dentist. This is the book that he wrote, and he suggests the use of the veneers for instance orthodontics or simulated straightening of the teeth is harmful. It is harmful to do some veneers to correct orthodontically, which I call instant orthodontics, especially for younger people with healthy teeth. Minor cosmetic or wear is not justification for porcelain and ceramic veneers. Tooth preparation, which may destroy 30% of the tooth surface during the tooth preparation of the veneers. After 10 years, 50% of the veneers are gone, need a retreatment, or no longer are in satisfactory conditions. This is the situation, the teeth that I took from Nondas. Nondas is a lab technician, very well known worldwide. He's a Greek lab technician. These are the teeth, as you can see on the upper left slide, with composite veneers. He changed them into ceramic veneers. Definitely he's the lab technician, but his partner, the dentist, as you can see, these were the preparations, the nice preparation, the excellent veneers, ceramic veneer that was done. You can see these pictures on his Facebook and website. These are the 12 veneers that were done for a very young lady that became Miss Universe. Miss Universe was 18 years old when she had all this treatment. My question is, would you do it to your daughter if it is to give her the smile? Look at this Miss America having a removable denture to replace a missing tooth, waiting for the end of the growth, and yet she was elected Miss America. Nobody knew, nobody noticed, as you can see. Even a temporary or nicely prepared work should not compromise the situation of the teeth. Thank you very much for your attention. I leave you with these reflections.